The second class of bronchodilators that I'm going to talk about are the anticholinergics. Now, when we're talking about the cholinergic effect, it's the other side of the autonomic nervous system. So autonomic just means like automatic, the part of the nervous system that we don't control. And so there's the adrenergic, which we already talked about with old Scooby-Doo. The cholinergic is sometimes, instead of fight and flight, it's referred to as the rest and digest part. And so here's Scooby-Doo. The other thing Scooby-Doo does besides running from monsters is he loves to eat, right? And so now you see why I like to use Scooby-Doo. So the rest and digest, all of the things that are used in digestion get turned on. And so you're having increased peristalsis in your stomach and intestinal tract, and you're salivating, and Scooby's big pink tongue always makes me think of that. And all of the things involved in digestion. We're talking about smooth muscle here. And so it's going to turn on the smooth muscle, turn off the skeletal. Like I said earlier, how our body is not a great multitasker. So a lot of times when the smooth muscle is turned on, it's going to kind of turn off the cardiac and the skeletal muscle. So your heart rate slows, your body's not worried about running from anything, and so skeletal muscles aren't getting very much attention, and all of your energy goes to digesting your food or eating and that kind of thing. Unfortunately, when we're thinking about smooth muscle, besides being in the bladder and the intestinal tract, it's also what lines our bronchial area, right? Our trachea and all of that. That's smooth muscle too. And so sometimes you can have, with a cholinergic effect, you can have what's called sorry for the pause. You can have what's called a bronchospasm, meaning just like peristalsis is the walls of the intestine moving the food on through, a bronchospasm is the walls of the smooth muscle that's lining your bronchioles being activated, just like with peristalsis. And so that's a cholinergic reaction. It's normal. And so sometimes we're going to use meaning opposite of cholinergics, to block the cholinergic effect and thereby reduce the bronchospasm. And the most well-known of these is the ipratropium, and a lot of these are going to end with that opium. They have absolutely nothing to do with narcotics. It's just a coincidence, but they do end with that, like ipratropium ends with that opium. And these are going to block the cholinergic effect. They're not as fast as the adrenergics, like the albuterol, and so they're not used as rescue inhalers, but they are used in longer-term prevention of bronchospasm. Then you're going to have the side effects of real similar to adrenergics. If it's blocking the slow heart rate, then you might have an increased heart rate. And probably the most common thing about anticholinergics is, remember Scooby's wet, slimy tongue? You're going to get dry mouth from these because it's going to block that cholinergic effect. So it's going to slow down your digestion. It might give you some urinary retention because, again, the bladder is smooth muscle, and it's going to give patients dry mouth because it's blocking that cholinergic effect. The last class of bronchodilators are the xanthines, and theophylline that I've talked about previously falls into this category. It's not used too much anymore, and so I'm not going to spend a lot of time on it. If you look in your textbook on page 500, you can kind of see why it's not used a lot anymore. Tons of side effects. Nausea, vomiting, diarrhea are going to go with a lot of the bronchodilators, especially the anticholinergics, because it's slowing down your gut process. But it's also in the side effects of the xanthines. Cardiac effects, hyperglycemia, all kinds of stuff, and they just aren't used that much anymore. The only one I've ever seen is theophylline, and it's very rare that I see that anymore. The next class is corticosteroids. These are your inflammation busters. These are the best thing that there is for relieving inflammation. And of course, inflammation is swelling, and so again, that's going to open up the bronchial tree so that you can get more air through by reducing the swelling. The only bad thing about corticosteroids, and this is a pretty bad thing, is that inflammation is part of our process of fighting off disease, right? So sometimes it gets out of control and we have too much inflammation. But there's also, since it's part of our way of fighting off disease, when you cut it off, you also reduce your ability to fight off disease. And so it can cause somebody to be immunosuppressed. Now, luckily, there are many ways to give corticosteroids. You can IV, IM, by mouth. There's hydrocortisone cream that you can put on topically, and then there's all the inhaled. There's steroid inhalers that look pretty much, they're just a metered dose inhaler, and then there's also nose sprays. And the inhaled corticosteroids have a lot less systemic side effects than the oral or the injectable. And it's the same with the topical. It does have some systemic side effects, but not nearly as bad as what you would get from the oral. And so you would never have a patient take oral corticosteroids for long periods of time. But patients do use the inhaled corticosteroids for years and years as kind of a prophylaxis. Remember us talking about that? Against things like asthma. An important thing to remember when patients are using corticosteroids inhalers is that they need to rinse their mouth after use, or they can develop what we call thrush, or an oral fungal infection in the mouth. It also might have a little bit of systemic effect by reducing their ability to fight off viruses, bacteria, fungi, things like that. Continuing on with asthma prophylaxis, the next group is the leukotriene inhibitors, and there's two mentioned in your textbook, montelukast and accolate. And montelukast you might know better as Singulair. It's a medication that's prescribed pretty often. We give lots of Singulair. The side effects, there's really not many. I mean, headaches, dizziness, pain, and maybe a little bit more increased risk of infection, respiratory infection, but they're rare. Most people can tolerate Singulair really well. I don't see accolate given too much because it has more side effects. And there's like a cascade of effects from what's called the inflammatory cascade, and this is just stopping it at a different point than what the corticosteroids do. One thing to note on these is that Singulair, or montelukast, is recommended for children ages 2 and over. The other one, accolate, is not. So in answer to the question that I have posted up here, which leukotriene inhibitor could she use, it would be Singulair. That's the only one that has been approved for children. Another medication for asthma prophylaxis are the mast cell stabilizers. I don't see those too much in practice anymore either. At one time, this cromolyn that's mentioned here, there was a nasal spray called Nasal Chrome. And when it first came on the market, it was the bomb and everyone used it. But just medications are kind of like fashion. They come in and out of style pretty quickly. And not a whole lot of people use Nasal Chrome anymore. You can buy it over the counter. But people didn't like it. It burned their nose, burned their throat, sometimes would cause some cough and bronchospasm, and just didn't work as well as some of the other things on the market. But I do want you to be familiar with it, that it is out there. Mast cell stabilizers, again, on that inflammatory response, just like the leukotriene inhibitors act on one part, the mast cell stabilizers are going to act on another part, just to stop that. So in wrapping up asthma prophylaxis, here's a picture that you will see a lot of times in doctors' offices, especially those that are asthma and allergy doctors. And it shows all of the different inhalers that there are. And I have the question, which inhaler first? And so at the top we have bronchodilators, then in the middle anti-inflammatories, which are going to be your corticosteroid inhalers, and then combination medications at the bottom. So if you're given a bronchodilator and a steroid or an anti-inflammatory, which inhaler are you going to give first? If you said bronchodilator, you're correct. And it really makes sense when you think about it. You want to open up the airways so that more of the steroid inhaler can reach where it needs to go. So when we're given two, we're always going to give the bronchodilator first. The other thing that we encounter is a lot of times the doctor's orders will say give 2 puffs. And that means 2 puffs from the same inhaler. And patients are notorious for wanting to just puff immediately and they're done. But they should be waiting 1 to 2 minutes in between puffs. And so if there's 2 inhalers, 2 puffs each on each inhaler, what you're going to do is use the bronchodilator first. 1 puff, wait 1 to 2 minutes, second puff, wait 5 minutes, and then do the steroid inhaler. So 5 minutes in between. And there is some variation. I looked this up and I found anywhere from 5 to 15 minutes, but I did see the most recommended was at least 5 minutes in between different kinds of inhalers. And again, at the bottom here, you can see rinse mouth following a steroid inhaler. That's always important to educate our patients on that. They can rinse their mouth, brush their teeth, whatever. We're going to pause here and then we'll cover the next half of this presentation.